In this video, we're going to discuss one of the other IV anesthetics called Etomidate. And similar to the video about propofol, we're going to first talk about mechanism. We're going to talk about dosage. We're going to talk about metabolism. And then we're going to talk about what it does to the heart, lungs, and brain. And then we're going to go over some special characteristics. So we're just keeping in line with that same format. Mechanism, dosage, metabolism, and then what it does to the different organ systems. So keeping with that format, Etomidate, it acts on the GABA A receptor. Remember, just like propofol, and I'm drawing here our GABA A receptor. This is GABA A, and GABA, the GABA ligand, binds to the GABA A receptor, and it causes an opening of this chloride ion channel, which enters the cell, causing hyperpolarization, decrease in action potential, and ultimately unconsciousness, which is the anesthetic effect. Etomidate binds, similar to propofol, it binds to a site on the GABA receptor, and what it does is it increases the affinity of GABA and its receptor. So similar mechanism of action to propofol. The thing is, Etomidate's chemical structure, which we won't really get into, is different than all of the other anesthetics. What I will say is that Etomidate's chemical structure, although I'm not going to draw it out, it is of the class called imidazoles. It's an imidazole. And the reason why I'm bringing this up is because it is lipid soluble at physiologic pH. So, physiologic pH. So, because it's lipid soluble at physiologic pH, you have to combine, similar to propofol, you have to combine imidazole or Etomidate with more water-soluble substances such as glycerol. And although I didn't talk about it in the propofol video, glycerol as well as soybean oil and egg lecithin are found in propofol. And it's the glycerol that will cause pain on injection. Just like in propofol, the glycerol is what's causing the pain on injection. So what you do is you give lidocaine, exactly like propofol, before injecting the anesthetic or injecting the Etomidate in this scenario. Okay, so we talked about mechanism. Now let's talk about dosage. So our dose of Etomidate is usually 0.2 to 0.3 milligrams per kilogram. You can think about, with propofol, it's 2 milligrams per kilogram. Think about Etomidate as, just move that decimal point to the left, 0.2 milligrams per kilogram. But you can have 0.2 to 0.3 milligrams per kilogram. And this dose, this induction dose, just like propofol, it'll get rapidly eliminated via redistribution. So from the plasma to other parts of the body, thereby losing the concentrations that you've built up on induction in the brain, and that allows for rapid emergence and wake up. Now we're going to talk about the metabolism. So metabolism and excretion. of etomidate. So etomidate, there are two ways that, or two locations where etomidate gets metabolized. So I'll draw our blood vessels here. And one of the ways that etomidate gets metabolized, and I'll draw my etomidate as E, is via plasma esterases. Plasma esterases. And what the plasma esterases do is they hydrolyze the etomidate and allows it to be in an inactive state. The other way that etomidate gets metabolized is similar to propofol. It's via the liver. However, it's not through conjugation, whereas propofol, the metabolism was through conjugation. With etomidate, the metabolism is through microsomal enzymes. So hepatic esterases you can even think of. So hepatic esterases. The etomidate and the etomidate that gets metabolized into its inactive form will eventually go to the kidneys, where they will be excreted. So metabolism is through plasma esterases, hepatic esterases. Excretion is through the kidneys. One must take caution when using this medication in patients with end-stage liver disease or end-stage renal disease. Now we're going to talk about etomidate's effects on the cardiac system, the cardiovascular system, on the respiratory system, and on the brain as well. So again, keeping with that same format, whereas propofol had pretty significant hemodynamic effects, etomidate causes minimal cardiovascular effects. So this makes etomidate an ideal induction candidate for patients who have coronary artery disease or undergoing any high-risk heart procedure or those with any cardiac disease. So it doesn't necessarily decrease your blood pressure as much as propofol does, and it's pretty protective of the heart as well. Now we're going to talk about etomidate's effects on the lungs. So there's our lung. And similar to its cardiovascular effects, etomidate has impacts the respiratory system to a lesser degree than propofol does. Whereas propofol caused apnea, etomidate doesn't do that as much. So it has a decreased respiratory effect than other anesthetics. And that may be useful for patients who come into the emergency department who have experienced some sort of trauma, and you're trying to preserve as much as you can a patient's respiratory status or ventilatory status. And now we're going to talk about, I'm running a little bit out of room here, so I'll draw it right underneath here. So etomidate's effects on the brain. So that's our brain. So etomidate causes a decrease in cerebral blood flow, just like propofol, and it causes a decrease in intracranial pressure. Etomidate preserves cerebral perfusion pressure. And another thing that it does is it acts almost as an excitatory stimulant. So etomidate can lower the seizure threshold which essentially means it can, if you want to invoke a seizure, or if you have a seizure that's going on, you give etomidate, that threshold to stop the seizure essentially gets lowered or decreased. So it's easier, in other words, for a patient to have a seizure or to induce a seizure. And because it is excitatory, etomidate increases what is called your SSEPs, or somatosensory evoked potentials. This we'll get into in a later video, but just keeping things simple, this somatosensory evoked potential is a recording that we use in the operating room in neurosurgery cases or spinal surgery cases. And essentially what the neurophysiologist does is they shoot an electrical signal up the body through the somatosensory tract, and they're able to record the response to that stimulus. And you can imagine in surgeries where you want to keep a close eye to make sure that the patient has the somatosensory intact, you don't want to use medications that depress that. So if you want to use medications that help preserve that or increase that, you use etomidate. There are other medications that you can use as well. But basically, etomidate doesn't allow for masking of the somatosensory evoked potentials. And then what we're going to do now is the last thing we're going to talk about are side effects of etomidate. I'm actually going to put it down here. Side effects. And because etomidate is excitatory, sometimes it causes myoclonus on induction, and you'll see that. One of the other side effects of etomidate is its effect on the endocrine system. I'm going to draw my kidney here. This is going to be my adrenal gland. And what etomidate does is it inhibits 11-beta hydroxylase. I'm going to draw my E here, inhibiting that. And the function of 11-beta hydroxylase is to ultimately produce cortisol and aldosterone. So if you inhibit 11-beta hydroxylase, you have decreased cortisol, decreased aldosterone, which could lead to adrenal suppression and insufficiency. And that could be potentially dangerous and life-threatening. So that's one of the big side effects and special characteristics that you need to know about etomidate. So to quickly go over one more time, etomidate increases the affinity of GABA to its GABA A receptor. It is an imidazole, lipid soluble, so it's combined with glycerol, and that causes pain on injection. So you give lidocaine to blunt that pain. Dose is 0.2 to 0.3 milligrams per kilogram, and its induction effects are rapidly eliminated via redistribution. Metabolism is through plasma and hepatic esterases and through renal excretion. Has minimal cardiovascular effects. It has a decrease in your ventilation to a lesser degree than propofol, and it decreases your cerebral blood flow and your ICP. It is excitatory, so it decreases your seizure threshold, and it increases your somatosensory evoked potentials. Side effects include myoclonus because of that neuroexcitation, and it inhibits 11-beta hydroxylase, which could cause adrenal suppression.